Hi guys, good evening. One second. All right, so can you all see me? Can you all hear me? Quick feedback. All right, guys. Good evening. Good evening. Sorry, I didn't know that we went live today. I was hoping the Backham team would actually inform me before going live, but okay, fine. So let's begin today. So yesterday we spoke about the basic anatomy of the stomach, and we tried to understand that what are the objectives and the line of component it is there. So today I'll be starting with a disorder in the stomach. We'll start with the congenital disorders, again a very interesting and an important one, and I'll pick it from there, right? So today's topic is going to be a very interesting topic, and that is your congenital hypertrophic pyloric stenosis. It is your congenital hypertrophic pyloric stenosis. Okay, just aligning my colors. Okay. So today we'll be talking about the congenital hypertrophic pyloric stenosis. Congenital hypertrophic pyloric, right? So we're talking about this topic today, that is your CHPS, or also called as the congenital hypertrophic pyloric stenosis, right? Now, very important and interesting topic. Remember, if you're also targeting the competitive exams like INICT or NEET PG or FMG exam, this is one of the most important topics, and this is also called as the Char Chand Panch Sitare wala topic, right? This is also what we call it as a very important one. Now let's try to decode this. Now when I say the word congenital, congenital का मतलब क्या है? जन्म से ही, that means जब से पैदा हुआ तब से ही problem है. So this is since birth. The problem exists since birth. Hypertrophy, there is increase in size. So what or where? Now this increase in size is usually in the circular muscles. It is in the circular muscles of the gut. Now, if you remember our BLS lecture on the esophagus, we discussed about the anatomy of the wall. That is your gut wall. The innermost is mucosa, then you have the submucosa, then you have inner circular, then the outer longitudinal muscles, and then the serosa if you are in the abdomen, or it is going to be adventitia. We know the serosa is nothing but what? It is nothing but your visceral peritoneum. So where is this increase in circular muscles? Notice it is going to be in the pyloric region, and that is resulting in stenosis. Stenosis is nothing but narrowing, and this narrowing of the pylorus will result in obstruction, and this is what we call it as the gastric outlet obstruction. This is what we call it as the gastric outlet obstruction. So since birth, there is increase in size of the circular muscles in the pyloric region, and that allows or causes the narrowing in the pyloric region, and that narrowing won't allow the content to move forward, resulting in gastric outlet obstruction, which is also commonly called as GO. No, sorry, it is called as GO, right? Right, don't get me wrong on that. So GO stands for gastric outlet obstruction. Now, why does it happen? We don't know. Since birth it is happening. So it is also called as idiopathic. It is also called as idiopathic. Now idiopathic hypertrophic pyloric stenosis. So either you can call it as CHPS, right? तो प्यार से क्या बोलते हैं? या तो आप इसको CHPS बोल लो या IHPS IHPS बोलो, फर्क ही नहीं. Congenital hypertrophic pyloric stenosis, or you can call it as idiopathic hypertrophic pyloric stenosis. It is better to remember as IHPS because the cause is unknown, so it becomes your idiopathic hypertrophic pyloric stenosis. Makes a larger sense. Now, so when you talk about the CHPS, how it is going to happen, what is the presentation, we'll try to decode it slowly and slowly. Now, it so happens a baby of CHPS, when you look at the presentation, right? So, in the clinical presentation of the congenital hypertrophic pyloric stenosis, the usual age at which you will see these babies is going to be between the 3rd to 6th week of life. It is the 3rd to 6th week of life. If I have to give you a single best answer, right? If I have to tell you what is the usual or the most common age of presentation, remember it is going to be 4th. It is going to be the 4th week, right? Now at this age, you will see the baby is going to present. Another interesting thing is it is more common in a male child. It is more common on a male child when compared to that of a female child. So the male child are more commonly affected. The male child are more commonly affected when compared to a female child. And the ratio, if you want to work it up, can anyone tell me what is the ratio at which you can see? Any quick feedback? I know the males are more likely to be affected than the females, but the question is how more often the males are going to get affected when compared to females. Any takers? Quick feedback on the chat box. Okay. नहीं बताओगे मैं बता दूंगा. रेशियो इज 4:1. इसमें और इंटरेस्टिंग क्या है, राइट? इट इज मोर कॉमन इन अ फर्स्ट बॉर्न मेल चाइल्ड. ठीक है, एक तो लड़का और वो भी घर का बड़ा बेटा, वो ज्यादा इफेक्ट हो जाता है. ठीक है, जिम्मेदारी भी तो ज्यादा होती है इस पे. ठीक है, so it is more common in first born, is more common in first born male child. This is going to be more common in a first born male child, right? So how or what it is going to present, let's try to understand, right? You take this as the representation of the stomach, and this is the pyloric region that continues into duodenum, which is here, right? Now it's saying at the level of the pylorus, which is going to be here, there is hypertrophy of the circular muscles. Now because of these hypertrophied circular muscles, now this outlet, that is the stomach going into the duodenum, or the passage of stomach to duodenum, gets narrowed down. Now as it gets narrowed down, the content cannot move forward, right? Hence the baby is going to be associated some amount of problem. Another very interesting thing is the bile duct that is going to come from the liver. It goes behind the duodenum and then opens onto the second part of the duodenum. So bile is going to excrete at this point, right? So this is the second part of the duodenum from where the bile is going to be excreted. Now how does this baby will land up to your OPD or to your clinic or to a surgery department, or let's say to a pediatric department, then refer to a surgery department? The chronology is important. Now if you understand the whole concept, now the baby is born, obviously it does not present exactly at birth, because by the time it becomes hypertrophied and gets more bigger and then causes obliteration, it usually takes 1 month of life. Since the birth, there is some amount of hypertrophy, but that hypertrophy becomes rampant or it becomes more progressive in the first month of life. Hence the symptomatic presentation is usually at the end of the first month of life. So होगा क्या? Mummy is going to feed the milk into the baby. The milk is going to go into the tummy and the milk is now going to fill up. अब milk बोलता है कि मुझे आगे जाना है, मुझे जाने दो, right? Now the problem is you need to understand. अच्छा, I'll ask you a very simple question. अब मुझे बताओ, milk is solid or liquid? A quick feedback. Milk solid है कि liquid है? Milk solid है कि liquid है? What do you think the milk is? Do you think it is solid or liquid? All those guys who are watching live, just give me a quick feedback. It will tell me how intelligent you are, or what is, like, how well you are able to apply the common sense. Milk is solid or liquid? भैया milk solid है कि liquid है? देखो, I have a feedback where the people are saying the milk is liquid. बेटा अब मैं आपसे सवाल पूछूंगा कि पनीर solid है कि liquid है? Milk आपने बोल दिया liquid है. पनीर solid है कि liquid है? पनीर is solid or liquid? पनीर क्या है? What is paneer? Is it solid or liquid? द पनीर इज सॉलिड। तो पनीर बनता कैसे है? मिल्क से ही तो बनता है। मिल्क कम्स इनटू स्टमक, द एसिड व्हिच इज प्रोड्यूस्ड बाय द पैराइटल सेल्स एक्ट्स अपॉन इट। अब मिल्क का बन गया पनीर, तो यहां पे बन गया पनीर, तो पनीर पनीर पनीर। दिस पनीर व्हिच इज फॉर्म्ड हियर इज नाउ गोइंग टू बी सॉलिड, ठीक है। तो द लिक्विड पार्ट जो पानी है वो धीरे धीरे करके शायद फिर भी बह जाए, लेकिन पनीर तो रुक जाएगा। द पनीर कैन नॉट फ्लो एनी फर्दर, right? So even though milk appears to be liquid, it is a solid feed, ठीक है। तो मम्मी ने दूध पिलाया, अंदर गया, पनीर बन गया। पनीर जा ही नहीं पाएगा क्योंकि आपका जो सर्कुलर मसल्स है वो उसको दबा के रख रहा है। अब पनीर जाएगा नहीं तो फिर कैसे, क्या प्रॉब्लम होगी? अब प्रॉब्लम हो जाएगी कि स्टमक इज नाउ गोइंग टू गेट डिस्टेंडेड, ठीक है। अब जो आगे नहीं जाएगा, ऑब्वियसली जो भी पानी और व्हाट आर द कंपोनेंट व्हिच इज प्रेजेंट इनसाइड इज नाउ गोइंग टू रिवर्ट बैक एंड दिस इज गोइंग टू प्रेजेंट एज वॉमिटिंग, ठीक है। एक तो खाना आगे नहीं जा रहा और ऊपर से पुशबैक हो जा रहा है, ठीक है। जब वापस आएगा ना आपको दिखेगा पनीर के चंक्स भी दिखेंगे, ठीक है। कभी देखना है इस वॉमिटिंग में, सो यू विल हैव दैट विदर्ड मिल्क दैट इज गोइंग टू बी प्रेजेंट। द फर्स्ट कंप्लेंट, द मदर इज गोइंग टू ब्रिंग द चाइल्ड with repeated, there'll be repeated episodes of vomiting, there'll be repeated episodes of vomiting. Mother is scared, mother is worried, अरे हाय दैया क्या हो गया, ये तो बंद ही नहीं करा, वॉमिट पे वॉमिट, वॉमिट पे वॉमिट, खिलाया वॉमिट, खिलाया वॉमिट, एंड नाउ शी इज वरीड एंड शी लैंड्स अप टू अ क्लिनिक और टू द ओपीडी और टू द इमरजेंसी। अब देखो इनिशियली है तो बच्चा ना, सर्जन्स बड़े लोग होते हैं तो बड़े लोग के पास इतनी जल्दी आता नहीं है कोई, तो पहले जाएंगे अपने बच्चों वाले डॉक्टर के पास, दैट इज गोइंग टू बी पीडियाट्रिशियन। और पीडियाट्रिशियंस आर ऑब्सेस्ड विद वॉमिटिंग, तो पूछेंगे हाँ बोलो क्या प्रॉब्लम है। मम्मी बोलेगी कि डॉक्टर साहब ये बच्चा ना वॉमिट पे वॉमिट, वॉमिट पे वॉमिट, एक के बाद एक वॉमिट ही किए जा रहा है, ठीक है। So you'll be like, okay, let's try to understand this. Now, as there is repeated episodes of vomiting, तो पहले पूछते हैं कि भैया बताओ कलर ऑफ द वॉमिटस कैसा है, जैसे दूध था वैसा ही है या फिर कुछ हरा है, कुछ काला है, कुछ पीला है, कुछ नीला है, बताओ किस कलर का वॉमिटिंग है। Now, if you apply common sense, as I told you, the content that goes in comes out in the same form. So hence, the patient will have same vomiting. मतलब बाइल तो मिक्स हुआ ही नहीं, बाइल कैसे होगा बेटा, बाइल यहाँ पे दूध पहुंचा ही नहीं बाइल तक, तो बाइल से मिक्स ही नहीं होगा, तो दूध दूध की तरह वापस आएगा, एंड दैट इज व्हाट वी कॉल इट एज, क्या बोलोगे इसको, बोलोगे नॉन बिलियस वॉमिटिंग। दिस इज व्हाट वी कॉल इट एज नॉन बिलियस वॉमिटिंग। फिर पूछेंगे इज इट प्री फीडिंग और इज इट पोस्ट फीडिंग, खाना खाने से पहले होता है या खिलाने के बाद, मतलब दूध से पहले कि दूध का। बेटा जब दूध होगा तभी ना वापस आएगा, दूध जाएगा ही नहीं तो आएगा ही नहीं, तो मदर बोलेगी ये तभी होता है जब मैं इसको दूध पिलाती हूं। तो दिस अकर्स पोस्ट फीडिंग, दिस अकर्स पोस्ट फीडिंग। तो फिर डॉक्टर साहब पूछते हैं कि मैडम वॉमिटिंग कैसे होता है। मदर बोलेगी क्या पागल है, वॉमिटिंग वॉमिट की तरह था, मुंह से ही तो निकलेगा, वही तो वॉमिट है। तो फिर डॉक्टर साहब बताएंगे नहीं मैडम आप समझो, सवाल ये है कि वो स्ट्रेट अप फ्रॉम द माउथ है कि एंगल ऑफ द माउथ, दैट मींस इट इज विद ग्रेटर थ्रस्ट और इट इज मोर एंटिसिपेटरी। तो मदर बोलेगी कि ऐसा लगता है कि ना जैसे फाउंटेन आ गया, फाउंटेन, बिकॉज द स्टमक इज गोइंग टू कॉन्ट्रैक्ट, राइट, एज इट कॉन्ट्रैक्ट बिकॉज इट्स अ डायनेमिक ऑब्स्ट्रक्टिव स्टेटस। नो, डायनेमिक ऑब्स्ट्रक्शन की वजह से, डायनेमिक ऑब्स्ट्रक्शन का मतलब होता है ऑब्स्ट्रक्शन ड्यू टू अ मैकेनिकल कॉज व्हिच इज प्रेजेंट इनसाइड द ल्यूमेन और आउटसाइड द ल्यूमेन, ठीक है। इट इज कंप्रेसिंग द ल्यूमेन, बेसिकली obliterating the lumen, so hence the content is not able to move forward, the stomach contracts with greater thrust and it reverts back. Now as it reverts back, now as it goes back, it is going to thrust it out, and that is what we call it as projectile vomiting. Now remember, if the obstruction is at or above the level of the pylorus, it is going to be projectile. Below that, it will be a non-projectile vomiting. In adults, the definition is different. In adults, we say if a vomiting is preceded by nausea, it is a non-projectile vomiting. If a vomiting is not preceded by nausea, it is called as projectile vomiting. सिंपल सरल भाषा में ये है कि अगर आपको नॉइजिया हो रहा है उसके बाद वॉमिटिंग है, दैट मींस यू आर एबल टू प्रेडिक्टेड, ये नॉन प्रोजेक्टाइल होगा। अगर आपका वॉमिटस विदाउट एनी नॉइजा, नॉइजा है ही नहीं और डायरेक्टली करके निकल गया, दैट इज व्हाट यू कॉल्ड एज प्रोजेक्टाइल वॉमिटिंग, ठीक है। बेटा स्टमक, सी ऑब्वियसली द पेरिस्टालिसिस, नो, the peristalsis will try to propel the content to the forward direction, लेकिन आगे जा ही नहीं रहा है. So what is going to happen? The intensity of the peristalsis will increase in order to push the content forward, लेकिन आगे तो बंद पड़ा हुआ है. Now as you know, when the pressure inside the stomach will increase, मैंने आपको क्या बताया था, यहाँ पे एक sphincter है ना, lower esophageal sphincter. I told you before also, sphincters works on the principle of pressure. ठीक है, तो जैसे ही यहाँ पे कॉन्ट्रैक्शन बढ़ने लगे, बिकॉज द इंटेंसिटी ऑफ पेरिस्टाल्सिस इज इंक्रीजिंग टू पुश द कंटेंट फॉरवर्ड, लेकिन कंटेंट बोलता मैं तो जाऊंगा ही नहीं. व्हाई? बिकॉज देयर इज ऑब्लिटरेशन ड्यू टू द हाइपरट्रोफी ऑफ सर्कुलर मसल्स एंड द स्टमक सेज नहीं, मैं तो पुश करके रहूंगा, एंड इट कॉन्ट्रैक्ट्स विद ग्रेटर फोर्स. नाउ एज इट कॉन्ट्रैक्ट्स विद ग्रेटर फोर्स, as it contracts with greater force, the pressure inside the stomach increases, sphincter relaxes, and it goes as vomitus. Hence it will be a projectile vomiting. All right, so I hope you're clear. Beta, Euro class is coming soon, don't worry. ठीक है, I know. Arise बच्चा, always there, don't worry, not leaving you. This is a regular class, that is, I know. ठीक है, I got you. ठीक है, so this is in the context of your projectile nature. So you have a non-bilious vomiting which is going to occur after feeding, and this is going to be projectile in nature. This is going to be projectile in nature. ठीक है, अच्छा. Now apart from this, nothing else. So mother has brought to you a baby who is a 4 weeks old child with repeated episodes of non-bilious vomiting which occurs post-feeding, which is projectile in nature. Now my question to you is, what else? What else will you see? तो मम्मी जब लेके आएगी तो हम बच्चे को एग्जामिन करेगा. तो ऑन एग्जामिनेशन, remember all the examination findings of the CHPH, CHPS, that is congenital hypertrophic pyloric stenosis, are best felt post feeding. So remember, best findings are seen post feeding. Okay, so what are the findings? So I'll ask the mother to feed the child. Now as the mother is going to feed the child, let's imagine that this is the baby who has been brought to us. ये baby है, cute सा baby. ठीक है, baby को पता नहीं है कि अंदर CHPS हो रहा है, baby को लग रहा है सब कुछ chill है. Right, now this is the esophagus, this happens to be the stomach, this happens to be duodenum, and the continuation across here. Now once you feed the baby, so I'll give नीली आंखें, छोटा सा मुंह, ठीक है. Now the baby is fed, the milk goes in, and now the milk is going to get accumulated into the stomach, right? So the minute you feed the baby and the milk goes into the stomach is going to get distended, right? So the first finding that you will see is presence of distension, that is stomach distension is seen. Now this distension of the stomach appears like a localized mass, and this localized mass is what we call it as the olive lump. This is what we call it as the olive lump. So the first thing you notice that this distended stomach appears to be like an olive lump. Now because the stomach is going to contract with greater force, and this will be the direction of peristalsis. This is going to be the direction of peristalsis to push. So obviously when you look at this, this is going to be the right side. This happens to be the left side. So what is the direction of peristalsis? It is going to be left to right. So the second thing I'm going to notice, there will be presence of visible peristalsis. There is presence of visible peristalsis, and this visible peristalsis because of intense contraction that is occurring inside the stomach. And more importantly, what is the direction of this peristalsis? This is going to be left to right. Now why this is important is, it is the gastric peristalsis. Remember the gastric peristalsis. The gastric peristalsis occurs left to right, whereas from right to left it will be a colonic peristalsis because your colon will be present like this. So this is how the colon's orientation is. If the peristalsis is right to left, it is colonic. If it is left to right, it is gastric peristalsis. Nothing spectacular about it, just a basic common sense how the organs are going to be arranged across here. So I have a baby who's a 4 weeks old. Patient is brought to the emergency, or let's say to the department, and now you see the first thing, there is distension of the stomach after feeding, and that distension of the stomach is perceived as olive lump with visible peristalsis. The presence of olive lump with visible peristalsis, right? Now Once you have seen this, obviously because of repeated episodes of vomiting, the patient is also going to look dehydrated. Now, this dehydration is due to recurrent vomiting. This is due to recurrent vomiting. Now, as I know there's a recurrent vomiting, the baby is going to get dehydrated. So I know there is some amount of electrolyte imbalance. So I would say basically send for serum electrolytes. So what is the electrolyte imbalance that we are going to expect in this baby? What is the electrolyte imbalance that you're going to expect in this baby? There are two ways of understanding or learning this. One, you mark it up, otherwise you understand. So we'll try to understand, that's our style, right? Now, every time the baby is going to vomit, so what does the vomit consist of? Every time the baby is going to vomit, the baby is going to vomit the gastric content. The baby is going to vomit the gastric content. Now, what do you have in gastric content? The gastric content is going to be rich in acid, that is your hydrochloric acid. It will be rich in water. और जहाँ पे भी पानी जाएगा वहाँ पे सोडियम साथ चलेगा, दोनों एक दूसरे के भाई हैं, ठीक है? So they love each other. Now, if I split them into basic ions, you would say this is going to be protons, this is going to be chloride, this is again water. I'm least bothered about it. Then you have sodium, right? Now, because you're losing protons and chlorides, if you're losing protons and chlorides because of the vomitus, the loss of protons, is what we call it as metabolic alkyl. क्योंकि protons lose हो रहा है, तो body will move towards alkaline status. So this is the first thing, that is metabolic alkalosis. Then it will result in hypochloremia. So the two electrolyte imbalance that I can see straight away is going to be metabolic alkalosis as well as hypochloremia. Now remember, sodium is the most cherished element of the body. We all know the normal level of the sodium that is going to be present is between 135 to 145 milli. It is 135 to 145 milliequivalents is normal, and body will always try to conserve sodium. Now, whenever there's excessive loss of sodium, how does the body comes back it to save? So what happens whenever there's water and sodium that is being lost? To conserve this, you have the renin, angiotensin, aldosterone system to kick in. So it will cause increase in secretion of aldosterone, right? So what is the basic function of aldosterone? That can be remembered by a simple mnemonic, that is ABCD, right? A stands for absorption. It is absorption of sodium and water, and that is what we wanted it, right? So this works on the nephron, and I want the sodium and water to be conserved, so hence it is going to do that. Now B stands for blood pressure maintenance. It maintains the blood pressure by creating vasoconstriction. It acts on the collecting duct as well as the distal convoluted tubule. And the last one is E. E stands for excretion of potassium. It is the excretion of potassium. So in order to conserve sodium, it is sacrificing potassium. Sodium has been conserved, the potassium is going to be lost. But remember, in the nephron, in order to conserve, let's say if this is the collecting duct, is the collecting duct. Now there are two ion gated channels, one which is going to conserve sodium and lose protons in the exchange. Another one is sodium is being conserved, losing potassium into the context. Okay, so there are these two pumps which are going to occur or right in order to conserve sodium, and both are under the influence of aldosterone. Problem क्या है? You are losing protons inside as well as potassium, right? Now loss of protons, right? So because of this, there is loss of potassium, so it will cause hypokalemia. It will cause hypokalemia, so that is understandable. But at the same time, you're losing protons also. Because body was already losing protons here. If you look at this whole concept, the body is already losing protons. It is already going into metabolic alkalosis. So whenever you're losing protons from the other end, body should conserve protons. But body बोलता है नहीं, मैं तो protons और दूंगा. क्यों? मुझे तो सोडियम बचाना है. ठीक है? So it is your love child. ठीक है? ये होता है ना कि when you love somebody too much, you're willing to go everything else even at a loss. That is what the body is doing right now because it is losing potassium, sodium. बोलता है कि यार मुझे सोडियम बचाना है के लिए मैं पोटेशियम की बलि दे दूंगा, मुझे कोई दिक्कत है ही नहीं. And in that context it is going to result in, see, when the protons in the urine will increase, the pH of the urine will become acidic, so it will be aciduria, but it is not supposed to happen, so it is a paradox. So this is what we call it as the paradoxical acid. I'm using the word paradox because body is already losing protons. It should have conserved protons, but rather than conserving it, it is losing further, hence resulting in paradoxical aciduria. So the electron imbalances, metabolic alkalosis with hypochloremia, hypokalemia, and paradoxical acid. Now this occurs in an early presentation. Now initially it is trying to conserve sodium. Now if there's a delayed presentation, if there is a delayed presentation, you will have all these electrolyte imbalance, but along with that the body will not be able to conserve sodium also, so hence it will loss of sodium resulting in hyponatremia. Hyponatremia basically tells you that there's a delayed presentation of this kid. अगर सोडियम भी ड्रॉप करने लगा इसका मतलब है बॉडी कॉम्पनसेशन के ऊपर उठ गया, मतलब इट इज ऑलरेडी लॉस्ट, इट इज एग्जॉस्टेड, अब ये कॉम्पनसेट भी नहीं कर पा रहा है, सो दैट्स एन एक्सेसिव लॉस एंड दिस इज द मोस्ट इंपॉर्टेंट कॉन्सेप्ट ऑफ योर सीएचपीएच. ठीक है, इसके बिना सीएचपीएच है ही. Is that clear? Did you all understand the basic concept of how the electrolyte imbalance is occurring in a patient of your CHPS? Rather than trying to memorize it, this is how you should actually understand, and you also know how or when to correct it. Is that clear? Is that clear? Okay. So I have a baby who has been brought to us with repeated episodes of vomiting. On examination, we see there's a distended stomach. I know you would want to see a baby also. I do have a baby with a similar presentation. I'm just going to share it on this screen. I want you to visualize this. Okay. Bam. Bam. Okay. Now you can see this is a 5 weeks old baby. I want you to observe something. Is this something? Can you see? Can you see this? Can you see this? There's something shifting, right? So initially when you saw this, so you will notice that there is a stomach distension post feeding, and this is what we call as olive lump. Now I want you to visualize carefully. This olive lump is now moving towards the umbilical. You can see it is moving from left to right. This is what we call as visible peristalsis, and this visible peristalsis is a telltale sign of your C. That is a congenital hypertrophic pyloric stenosis. Is that clear? Right. So usually the question will be a 4 weeks old baby who's been brought to your emergency with a lump which is present in the left upper quadrant of the stomach, and you see this is going to be a localized lump, and you see the whole lump move from left to right, and this is what we call as visible peristalsis. And visible peristalsis is a telltale sign of your CHPS. Okay, it's a telltale sign of your congenital hypertrophic pyloric stenosis. Right. Now I have a baby who's been presented to us. Now what would you like to do? So I have a baby for a repeated episodes of vomiting. This is the presentation. On examination, these are the findings, and on an electrolyte imbalance, this is what we see. Right. Now in order to investigate, in terms of investigation, you can do a contrast imaging as well. Right. You can do a contrast imaging. Now, in a contrast imaging, I will give the baby iohexol contrast. It's an iodinated contrast. Iohexol is iodinated contrast to swallow. And when the baby is going to swallow the iodinated contrast, what is going to happen? Now, this is, as you can see, this is going to be hypertrophied segment. Right? So, when you give this contrast, you will see the contrast is going to pass through this area. So the entire contrast that goes in, it comes across here, it is going to pool. So there's a pooling of contrast which you will see here, and this pooling of contrast will pass through this and then the contrast will again go out. So when you look at this, when I isolate, you see the contrast is going to be filling up like this, and then it will be the duodenal cap is going to fill up like this. The contrast imaging would look like this. Now this is what we like. It looks like a train track that is present. It looks like a train track, and then this balloons out. So this is what we call it as the double track sign. If I have to just isolate this particular segment, this is what we have, the double track sign. This is what we call it as a double track sign. This is what we call it as the mushroom sign. This is what we call it as the mushroom sign. I'll show you the images as well. Okay. On the other hand, the investigation of choice is going to be an ultrasound. The investigation of choice for CHPS is going to be an ultrasound. In the ultrasound, what you're going to do is you're going to measure the thickness and the length of the circular muscles, right? You will measure the thickness as well as the length of the circular muscle. Now, if the thickness is more than or equal to 4 millimeters and length is more than or equal to 16 millimeters, then it is a confirmatory diagnosis of congenital hypertrophic pyloric. Then we'll call it as the congenital hypertrophic pyloric stenosis. If you look at radiologically, your radiologist will tell you that you will find signs like antral nipple sign. This is called as the antral nipple sign that is going to be seen on an ultrasound. Okay, it will appear like an antral nipple sign. Okay. Now, if I have to show you the images, just give me a second. I'll just put up the images. One second. All these are in my phone. I forgot to translate onto my iPad. I'm doing it right now. इंग्लिश में पढ़ाओ बेटा, इंग्लिश में ही पढ़ा रहे हैं. ठीक है. So this is the ultrasound image that you can see. So when I say the length and the thickness, we say this, as you can see, the lumen of the stomach, which has been depicted here. These are your hypertrophied circular muscles. So I will measure the entire length of it. This length that you're looking at, this length should be more than or equal to 6 meters, and this is what we call it as the thickness, right? This thickness be more than or equal to 4 millimeters to call the baby is having CHPS. Okay, call the baby is having CHPS. Is that clear? Is that clear? Quick feedback. Okay. So this is with respect to congenital hypertrophic pyloric stenosis imaging per se. कोई सवाल, कोई शक? ठीक है. Now the baby is known to have the congenital hypertrophic pyloric stenosis, diagnosis बन गया. अब हम बात करेंगे management. So how would you like to manage? Talk about the management of congenital hypertrophic pyloric stenosis. Now everything is important, so we'll talk about the stepwise. Now, what is the first line of management? The first line of management is going to be the electrolyte. It is the electrolyte correction that we already spoke. ठीक है, क्योंकि patient को पहले electrolyte imbalance है, so you have to correct it. Now we say what is the most important electrolyte to be corrected? It is chloride. After the chloride, it is potassium, Usually sodium is not deficient, so you don't need to worry about it. This is the order of correction. But if the hyponatremia is there, then the order, you should correct everything, but the order of preference for correction is sodium first, followed by chloride, followed by potassium. So this is the order of electrolyte correction that you need to follow in CHPS. So once you have done, the second line of management is going to be surgery, and the surgery of choice is going to be your Ramsted's. It is your Ramsted's pyloromyotomy. It is your Ramsted's pyloromyotomy, right? Now, in a Ramsted's pyloromyotomy, what are you going to do it? So Ramsay's pyloromyotomy का concept very simple. I'll try to explain it to you. Now, let's say if this is the esophagus and this happens to be the stomach. Now, the whole problem here is because of hypertrophy of the circular muscles. So, if I have to give you in a nutshell, so if this is how the circular muscles are going to present, so hypertrophy of the circular muscles at this particular site, hypertrophy of the circular muscles at this particular site is what is causing the narrowing of this passage. So, if I have to depict the lumen, this is how the lumen is present, right? So lumen is so narrowed down. So lumen is so narrowed down, whatever is going to be going inside this is not able to pass, right? So if I take a cross section out of it, let's take the cross section from here and try to blow it out of proportion and see that what can we provide. When you look at this is the inner lumen and the outer component. So this is how a normal opening would have been present. Now because of hypertrophy of the circular muscles, now this has become like this and the opening has become quite small. Opening has become quite small, right? So how do you allow this to happen? The opening is becoming smaller because the circular muscles is compressing it. Now what if I excise the circular muscles? Hypertrophied muscles, if I excise it, what is going to happen? I am now going to create an opening. I'm now going to create an opening into the muscle, right? So the innermost layer, if I have to give you the same objective, right? The innermost layer that you have is the mucosa that is present. Surrounding the mucosa, you have the submucosa which is present, right? Now, the minute you excise this circular muscles, you're now allowing the lumen to expand. Now, as you allow the lumen to expand, you will notice because you have opened up the circular muscles, it has become like this. So, see, the bulk is still the same, but what it does is it allows the inner lumen to expand. It is allowing the inner lumen to expand, including the submucosa. Now, if this expands, so it is creating more space. Now, if it creates more space, obviously the content here is difficult to pass, but here the content can pass with greater ease. Here the content can pass with greater ease, and this is what we call it as Ramsted's pyloromyotomy, where you're dividing the circular muscle. It is what we call it as the longitudinal division. This is what we call it as the longitudinal division of circular muscle. Now, this can be done both with open method as well as laparoscopy. In current trends, minimal invasive surgery is the norm. So when I say surgery of choice is Ramsay's pyloromyotomy, but remember it is laparoscopic. Ramsted's pyloromyotomy is preferred over open pyloromyotomy. Now, the minute you do this, the mucosa is going to pop out. This is what we call it as mucosal pop sign. This is what we call it as the mucosal pop sign. So during the surgery, when the mucosa pops out, and this is how you're going to see. Hi Adya, I didn't see that you have joined the lecture. Adya, I hope you know all the details. Okay, so when you grow up, you have to read this also. Those who don't know, Adya is my daughter. She's 5 years old, and she loves attending my lecture. I told her not to, but she still does. We all love you, Adya. Now let's go back and sleep. All right, it's your time. Bedtime, bedtime. Bye bye. Chalo. Okay. So this is with respect to your entire discussion on CHPS? Oh, sorry, I missed that. 6 years, 5 complete. All right, chalo. Now, I know you have not seen the CHPS surgery, or if you have seen, great. I'll show you one of the videos that we have. Again, we are going to play it across. Okay? And in 4, 3, 2, 1, and bam. Okay? So this is your Ramsay's pyloromyotomy. You can see this is the stomach, as you can see, and this is the pylorus which has been distended. Okay? Now what we are going to do is we are going to mark an incision. This is, see this whitish layer that you see, this is your hypertrophized pylorus or the circular muscles which are present. I'm going to make a small dots here to mark my incision. This is your longitudinal pyloromyotomy. You are going to incise longitudinal. You're going to incise it longitudinally, so hence it is going to have a longitudinal incision. You're going to mark it dot 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 dot, and then you're going to split it across. Okay, so in a bit you will see making dot 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 dot, and now we are going to split it. Put it here. Now this is a Maryland forceps, right? With the help of Maryland forceps, I'm going to dissect it gently, right? As you dissect it gently, you will see that the entire components of the circular muscles will divide and the mucosa will pop out. We'll wait for the mucosa to pop to see what is a pop sign looks like. Aaja bhai. Pop, 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 pop. Okay, now you can see that whitish layer. Yo, and hold it. Yeah, you see that? That's your mucosa pop. We call it as the mucosal pop sign. Okay. Here you can see the mucosal pop sign. So this mucosal pop indicates that you have disrupted the circular muscles, allowing the mucosa to go out, and you have more space for the components to move around. Right now, this is what we call it as the Ramsay's pyloromyotomy. Okay. So going inside, making a longitudinal insertion, splitting the circular muscles, allowing the mucosa and the submucosa to pop out, and this is what we call it as the mucosal pop sign. Right. So this is what you should know all the context of CHPS, that is your congenital hypertrophic pyloric stenosis, right? This is it's an elective surgery. You have to correct the electrolytes first, put a nasogastric tube, decompress the stomach of the baby, and then take care of it. Once the electrolyte balance is put back, then you put it as elective surgery. Dushmesh Bhatt, beta sahi mein yaar nahi. Yeah, looking at Adya, I don't want her to be like, the race that we are into. I don't know, going back, it can be anything. But if she's preparing for NEET at the age of 6, then yeah, I think that's the end of the NEET's preparation. Okay, it's too competitive even to think about it. Chalo. But if I ask Adya if you want to be a doctor, Adya says, I don't want to be a doctor, right? She's more interested being a teacher. So I think there's a lesser competition. Chalo. All right, so any more questions? If no more questions, we're done for today. That's the only topic that we have designed it for today. So we thought we'll take it a bit easier on this side. So today we did CHPS. Tomorrow, tomorrow might be a little bit tricky because I have an OT. There's a duty tomorrow, and at the same time, I have a flight back home also, right? So tomorrow's lecture, I'll try to put it on Thursday, right? We'll not have a lecture tomorrow. We'll have a lecture on Thursday. So we'll see all you guys on Thursday. Okay. Until then, thank you so much for joining today. Good night. Take care. Bye bye. I'll share you the notes. You know where to get the notes. You know where to get the notes. If you want the notes, you want to ask any questions, any queries, my Instagram is the surgery guy. Okay. This is on my name. This is the channel that we have in both Insta as well as Telegram. It is by my name, that is Dr. Sandeep. Any questions, any queries, reach us down here. Right. Thank you so much. Take care. Have fun. Bye.